Okay, we're going to get started. We have many of us in the room already. So good afternoon. My name is Priscilla Calvache. I am the Assistant Director for Lupus Programs and Community Engagement here at HSS. Today, I'm excited to partner with the HSS Lupus and APS Center of Excellence in honor of Lupus Awareness Month and welcome you all to this important presentation. I'd like to thank you all for joining us this afternoon and especially for submitting your thoughtful questions and comments during registration. Today, I'm accompanied by my esteemed colleague, Allison Paisner, who is the manager for our Lupus and APS Center of Excellence here at HSS. Allison will join us a little later to facilitate the question and answer portion of the program. Before we get started, some brief housekeeping rules. Participants will be muted during the presentation, but we're highly encouraging you to please use the chat icon to send your questions and comments throughout the presentation. We will have time to review your questions at the end of the presentation, and Dr. Lieber will also be addressing some of the questions submitted at registration. Lastly, I'd like to introduce our program evaluation. Your feedback is incredibly important to us and really helps us to inform our future programs. So we will be embedding that survey link in the chat box and kindly ask you to please complete that survey at the conclusion of today's program. At this time, it is my pleasure to introduce our speaker this afternoon, Dr. Sarah Lieber. Dr. Lieber is an assistant attending physician at Hospital for Special Surgery and an assistant professor of medicine at Weill Cornell Medicine. Dr. Lieber specializes in the care of adults with rheumatic conditions, including systemic lupus erythematosus. Her research focus is aging in SLE, an application of aging-related concepts such as frailty across the lifespan in adults with rheumatic conditions. Her research has been supported by HSS, the Rheumatology Research Foundation, and the National Institutes of Health. Today, Dr. Lieber joins us to present on understanding laboratory tests and results for SLE. Welcome, Dr. Lieber.
Thank you so much for that really kind introduction, and thank you so much to everyone in the audience for joining us today. We realize it's a busy lunch hour for everyone, and thanks as well for submitting so many really thoughtful questions in advance. I'm going to do my best to cover as many as possible over the course of the presentation, and we anticipate that we'll have a few minutes at the end to address additional questions as they arise. So thank you again, and today we'll be speaking about understanding lab tests and results for systemic lupus. I was just saying that just to get started, I'm sure that many in the audience are familiar with lupus, either from their own experience or from the experience of a friend or a loved one. But by way of introduction, lupus is a chronic autoimmune condition, and as many people are aware, the manifestations can vary quite a bit by individual. But some of the common manifestations include fever, fatigue, various types of rashes, joint pain and swelling, and involvement of different organs, such as the heart and the kidneys. And I think really an ongoing theme of today's talk, with a focus on lab results, is going to be that lupus and the interpretation of lab results varies quite a bit with individuals. So it's obviously very important to have a dialogue with your rheumatologist and other healthcare providers to sort of help understand the manifestations of lupus and some of the common lab results, but we're going to be covering a variety of lab results in more detail today. So what is the purpose of lab tests in lupus? So there are a variety of purposes that we consider as we're checking labs, both at the time of helping us make the diagnosis and sort of over the course of one's monitoring for the condition. So one of the primary purposes is really to help make the diagnosis of lupus. There are a number of conditions that can have symptoms that are similar to lupus, whether other systemic autoimmune conditions or other medical conditions that are not considered autoimmune. Other reasons for checking labs in lupus over time include prognosis, sort of getting a sense of what the anticipated disease course or manifestations will be, monitoring over time, both of the course of the condition and potentially side effects of medications. And of course, we're checking labs to assess the response to the treatments that are recommended by your rheumatologist and other members of the healthcare team. So there are quite a few tests that can potentially be checked in lupus, and the list that I'm presenting here certainly is not an exhaustive list, but common lab tests that are checked in the context of lupus at diagnosis or over the course of the condition are listed here, and we'll be reviewing them in further detail as the talk progresses. So many of you may recognize anti-nuclear antibody, or ANA, which is quite a common test in this context. Anti-double-stranded DNA, or dsDNA, C3 and C4, which are the complement levels, complete blood count, often abbreviated as CBC, comprehensive metabolic panel, often abbreviated as CMP, erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP. These are inflammatory markers. Urinalysis with urine protein and creatinine, which are used to calculate a ratio. Anti-Ro, also known as SSA, and anti-La, also known as SSB, anti-Smith, anti-U1 ribonucleoprotein, often abbreviated as RNP, and what are called the antiphospholipid antibodies, including lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein. And just to step back, with the exception of urinalysis and urine protein to creatinine ratio, the remainder of the tests that I've listed here are collected by blood draw. A urinalysis, as the name implies, is collected through a urine sample. So the tests listed here are often checked at the time of diagnosis. Certainly, there may be other tests that are checked to distinguish lupus from other systemic autoimmune conditions or other medical conditions that may be considered. And the tests that are listed here are often checked over the course of monitoring, just to look at disease activity and some of the other features that we mentioned and we'll go into further over the course of the talk. Certainly some of the other tests that I've sort of primarily grouped with diagnostic tests are checked at points over the course of the illness, although not necessarily at every visit, and sometimes they're not rechecked. You know, the antiphospholipid antibodies in particular are sometimes rechecked at later points, depending on the clinical scenario. So I'd like to step back for a moment and share with you some of the criteria that are used by rheumatologists and other specialists to help make the diagnosis of lupus and sort of think about them in the context of lab results, which is our focus today. So these are considered the lupus classification criteria, and it's important to note that they were really developed for identifying individuals for research purposes, for participation in research studies, but they're often used by rheumatologists to help make the diagnosis of lupus. There have been several iterations of the criteria over the years. This most recent set of criteria was introduced in 2019 based on very extensive discussion with experts, and it was introduced by the American College of Rheumatology and the European counterpart, which is called EULAR. So the criteria here first include sort of a screening test of ANA with a titer or a level of 1 to 80, and assuming that this criteria is satisfied, then we consider some of these other symptoms and findings as well as lab results in helping make the diagnosis of lupus. So as you can see, one of those symptoms or manifestations we consider is fever. The next are hematologic manifestations, which refer to blood counts. So leukocytopenia and thrombocytopenia are often present, and these refer to low white blood cell count and platelet counts, as well as autoimmune hemolysis, which refers to low blood counts related to the overactive immune system, chewing up or hemolyzing the blood cells. Other manifestations that are considered in making the diagnosis include neurologic and psychiatric manifestations, that include mental health and mental status changes. And just to pause for a moment, there may be many causes of some of these symptoms or lab findings. And so when these criteria are being considered to help make the diagnosis of lupus, the assumption is that they're felt to be attributable to lupus and that other possible causes of some of these symptoms and findings have been evaluated. To move on, other symptoms and findings that are considered would be hair loss, which is known as alopecia, oral ulcers known as mouth sores, rashes such as subacute cutaneous or discoid lupus or acute cutaneous lupus. Other criteria that would be considered would be pleural or pericardial effusion, which refers to fluid in the lining of the lungs and the heart, and acute pericarditis, which refers to inflammation of the lining of the heart. Also considered would be musculoskeletal symptoms like joint involvement, renal or kidney symptoms, including protein in the urine or evidence on a kidney biopsy of findings under the microscope that are indicative of kidney inflammation, as well as certain lab tests, such as the antiphospholipid antibodies, complement proteins, which typically are low in lupus or often can be, as well as lupus-specific antibodies, such as double-stranded DNA or SMIF. It's important to emphasize that not all of these criteria need to be present at the time of diagnosis. There's a scoring system essentially, to help accumulate the criteria and help support the diagnosis of lupus. And it's also important to emphasize that there are lupus manifestations that may not be included on this list. So really the labs, as you can see, are taken into the context of these and other symptoms to help the rheumatologist and the medical team overall make a diagnosis of lupus. You know, there's some instances where a diagnosis of lupus may be more overt, such as when there are multiple lab findings or an overt finding of kidney inflammation on the kidney biopsy. And there are other situations where the diagnosis, which is always nuanced, may be especially nuanced, where there are fewer lab findings present, or some of the, not all of the symptoms are present. So just to step back, because this question comes up quite frequently, to talk a little bit about lupus and related conditions and some of the terminology that's used in the context of the diagnosis. So we're talking primarily today about systemic lupus erythematosus, known commonly as lupus, which is the diagnosis whose criteria I reviewed in the prior slide. There are some instances where the term incomplete lupus or probable lupus or borderline lupus may be used, where a person is experiencing a variety of symptoms and has certain laboratory markers that are suggestive or highly suggestive of lupus, but the rheumatologist at the time of diagnosis or at some later point is not able to make a firm diagnosis of lupus, or feels that partial symptoms are present. There are other instances where there may be other findings suggestive of lupus or other lab abnormalities that suggest lupus or potentially the evolution of other related connective tissue diseases. And sometimes the term undifferentiated connective tissue disease may be used. So these are sort of other terms that are used that are related to lupus and that you may hear used. So I felt it would be helpful to address some of this terminology. But today we'll be focused primarily on systemic lupus. So let's sort of dive into some of the specific lab tests that are often tested in the context of diagnosis and monitoring in lupus. So the first test that's often checked is ANA, or anti-nuclear antibody. This is an antibody that may be indicative of an overactive immune system. It's often expressed as what's called a titer. So for example, you may see a lab report indicating 1 to 80 or 1 to 160 or 1 to 320, et cetera. And this refers to how many times a blood sample can be diluted and it remains positive. There's a lot of discussion about the presence of ANA in lupus, and the experts who developed the criteria that I presented previously opted to include it as sort of an entry criteria. It's felt to be present in almost all individuals with lupus, but certainly there may be exceptions. It's important to note that it's not specific to lupus. It doesn't guarantee the diagnosis. It's present in somewhere in the ballpark of about 10% of the US general population and worldwide. Some estimates feel that it's present in even more people, without an overt autoimmune condition. It's also found in other conditions, for example, autoimmune thyroid conditions and a variety of other conditions. So having a positive ANA in and of itself really needs to be taken in the context of other lab results and other lab findings, since it can suggest a number of things or be present even in the absence of an overt autoimmune condition. As I mentioned earlier, it's really used to help make the diagnosis of lupus. There may be some circumstances where it may be rechecked at a later time, but in general, it's not considered a disease activity marker that allows us to monitor disease activity. It's really considered a diagnostic marker. So the next test that's frequently checked would be anti-double-stranded DNA. So this is an antibody that binds to DNA in cells. Estimates may vary, but it's found in somewhere in the vicinity of 50 to 80% of individuals with lupus. It's not required for diagnosis. There's certainly plenty of people with lupus who won't have a double-stranded DNA present at the time of diagnosis or over the course of their condition. And it also doesn't guarantee a diagnosis, though I will say that double-stranded DNA is seen uncommonly in other conditions. For example, we don't typically see it in rheumatoid arthritis or other autoimmune conditions. And it's also important to note that the level is often felt to correlate with lupus disease activity. So this is something that you'll frequently see rheumatologists check from one visit to the next, though we certainly do see scenarios where people may have a persistently positive double-stranded DNA, even when they're felt to be optimized, on their treatment regimen and feeling well. So again, sort of the recurring theme here is that we really do take these lab results into context as we're making the diagnosis and monitoring people over the course of their condition. So the next set of tests that are frequently checked at diagnosis and over the course of the condition are called complements, which are C3 and C4. These are proteins that are typically involved in the immune response to microbes, so infections, that become activated and consumed in lupus as part of the overactive immune response, even in the absence of an infection. We typically think of low levels occurring with lupus disease activity, meaning as opposed to high levels. Though again, I would emphasize they're not required for diagnosis and they don't guarantee the diagnosis. They can be seen in other contexts and other conditions. For example, some people may have complement deficiency from birth. So the next set of tests that are usually checked, particularly at the time of diagnosis, are anti-Rho or SSA and anti-La or SSB. These are other antibodies that bind to proteins present in cellular structures. Estimates, again, may vary. As you can imagine, there's been a lot of research on these different antibodies, but they're found in somewhere around 30% for Rho and SSA and 20% for La or SSB of individuals with lupus. Again, they're not required for diagnosis and they don't guarantee the diagnosis. They're found in other conditions. For example, most notably primary Sjogren's syndrome. So, as many of you may be aware, Sjogren's syndrome is another autoimmune condition that's often associated with dry eyes and dry mouth and potentially other organ manifestations. And Sjogren's syndrome can be seen on its own or sometimes in association with lupus or other autoimmune conditions, such as rheumatoid arthritis. Again, when these antibodies are present, they may be associated with dry eyes and dry mouth and certain types of sun-sensitive rashes, and also of relevance to people who are considering childbearing. These may cross the placenta and be associated with neonatal lupus, and so there are discussions with your rheumatologists and recommendations in place for screening purposes in the context of childbearing. So the next set of antibodies that are often checked at the time of diagnosis would be Smith and RNP. So Smith binds to proteins attached to RNA in cells, and RNP binds to proteins present in cellular structures. Again, estimates may vary, but Smith is found in around 10 to 50% of people with lupus, and RNP is found in up to 70% of people with lupus. As you're sensing from all of these slides, they're not required for diagnosis. Many people may not have them, and they don't guarantee the diagnosis. I will say that Smith is really found particularly in people with lupus. RNP, in contrast, is seen in other conditions. For example, the related condition, mixed connective tissue disease, that's considered a distinct condition from lupus. So next we'll talk about the antiphospholipid antibodies. So these are antibodies that bind to proteins present in cellular structures. Anticardiolipin is found in somewhere around 60% or up to 60% of individuals, and beta-2 glycoprotein is found in about 25%. There's also another antiphospholipid antibody called lupus anticoagulant. These are not required for diagnosis and they don't guarantee the diagnosis. They can be found in other conditions, most notably primary antiphospholipid syndrome. So as many of you may be aware, there's a condition called antiphospholipid syndrome that can be associated with blood clots and pregnancy complications. This is sometimes seen on its own, meaning primary antiphospholipid syndrome, and other times it's seen in the context of lupus or other autoimmune conditions. And so, these antibodies are pretty characteristic for that condition. When present, particularly at higher levels, they can be associated with higher risk for blood clots and pregnancy complications. So let's move on to some other lab tests that are checked at diagnosis as well as over the course of treatment and monitoring in the context of lupus. We can talk first about the CBC, or complete blood count. This is a very common test that's checked really in a lot of medical contexts. It's really not exclusive to rheumatology. So the components of the complete blood cell, of the CBC, are the white blood cell count, the hemoglobin and hematocrit, which reflect red blood cells, and the platelet count. So a common finding in lupus is what's called leukopenia. You may remember this from the criteria that I shared with you earlier. This is a low white blood cell count. Another common finding in lupus is what's called anemia, which refers to a low hemoglobin or hematocrit. These are measures of red blood cells. There are a variety of different reasons why someone might have anemia when they have lupus. Common reasons that are directly related to lupus would be anemia of chronic inflammation. So the idea that the inflammation itself induces certain changes that cause a low blood cell count. Another possible cause is autoimmune hemolytic anemia. This is a context in which the overactive immune system is associated with red blood cells being chewed up essentially or hemolyzed. And there are additional blood tests that can be checked to sort of distinguish between these two causes. I would also note that people with lupus can have other common, forms of anemia that are not necessarily exclusive to lupus. So for example, iron deficiency anemia or vitamin B12 related anemia, and rheumatologists or primary care doctors or other associated healthcare providers may commonly be checking things like iron studies or B12 levels in people with lupus to sort of try and tease apart why the anemia is occurring. Another common finding in lupus would be thrombocytopenia or low platelet count. I would say that a lot of these findings are present in people at various points in their diagnosis, but certainly not in everyone. And I will also say that if a new lab finding appears in the context of other active symptoms, it may indicate that the lupus is more active, but we certainly see people who have chronically mildly low white blood cell counts or platelet counts, even when their treatment is otherwise considered optimized and they're otherwise feeling well. And sometimes this is something that the rheumatologists and associated specialists may monitor. So next we'll talk about the comprehensive metabolic panel, often abbreviated as a CMP. So the components of this would be sodium, potassium, chloride, bicarbonate, blood urea, nitrogen, creatinine, and glucose. And many people are familiar with this lab test or set of lab tests, both from rheumatology and other general medical contexts. This is a very sort of common set of labs that are checked for a variety of reasons. The focus of checking these tests, although certainly rheumatologists are looking at everything, for rheumatologists is really to monitor kidney function. So blood urea, nitrogen, and creatinine, really particularly creatinine, are tests that we use in the blood to monitor kidney function. An elevated creatinine can indicate kidney dysfunction. Anytime someone develops an elevated creatinine in the context of a diagnosis of lupus or when that diagnosis is being made, the antenna of rheumatologists and related colleagues such as nephrologists who are kidney specialists are raised, to look to see whether the lupus has come to involve the kidneys through kidney inflammation. But I would say that there's certainly a variety of other causes of kidney dysfunction that are more general that we also, of course, keep in mind as we're sort of assessing these blood tests. Certain medications, not drinking enough fluids, they're really a variety of other causes. So the rheumatologist is always taking a look at this in the context of the other blood tests and the urine studies, which we'll cover, to determine whether or not changes in these lab values are indicative of lupus involvement. I also wanted to just mention, although the glucose isn't highlighted here, this is a question that often comes up related to the glucose. Many people with lupus, as many in the audience are aware, are on steroids. And one potential side effect of steroids is that they can raise the blood sugar. And so, glucose in condition with a blood test called hemoglobin A1C are often monitored, in conjunction with the primary care doctor in thinking about the potential side effects of steroids. I will say that the glucose in this context is often impacted by a variety of factors, like when you last ate. So often, if there's concern about elevated blood sugar or diabetes, other tests will be checked. The comprehensive metabolic panel also includes liver function tests. So we think about AST, ALT, alkaline phosphatase, bilirubin, albumin, protein. Calcium is also included in the metabolic panel, but that's not considered a liver function test. That's an electrolyte. Rheumatologists are certainly monitoring liver function tests. If there are changes in the liver function tests, those can be quite nonspecific. Certainly, they can be seen in association with lupus itself. Other reasons why liver function tests may change, may not be related to lupus. Certainly, there are medications that can be associated, certain types of infections, other findings intrinsic to the liver itself. And also, we'll touch on this a little bit later, but some of the medications that are used to treat lupus, we're also monitoring the liver function tests. I would also add that the protein and albumin, while generally considered part of the liver function tests because they're produced by the liver, we often look at the albumin in the context of monitoring people's kidney function and kidney inflammation in the setting of lupus, because when people's kidneys are inflamed in the setting of lupus, or excuse me, there's inflammation in the kidneys, there can be some leakage of proteins and albumin. So sometimes you'll see a low albumin in people who have lupus nephritis or inflammation of the kidneys. So next we'll move on to some common inflammatory markers that are checked. So erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP. These are considered nonspecific inflammatory markers. They can be elevated in other contexts. So for example, when the diagnosis of lupus is being made in the early stages, they're certainly not definitive to lupus. They're taken into account with the other symptoms as well as other laboratory markers. For example, they can be elevated in other inflammatory conditions. They can also be elevated in other sort of non-autoimmune conditions, for example, in the setting of infections. So that's important to keep in mind. But assuming other conditions have been excluded and there's, not clinical concern, for infection or certain other types of conditions that may be associated with elevated inflammatory markers, we often use the inflammatory markers, ESR and CRP, to monitor, at visits as one of the ways that we think about disease activity. Often in active disease, people's levels of ESR and CRP may be elevated. Certainly there are instances where they can be elevated even if treatment is felt to be optimized, and people are otherwise feeling well, and may be monitored to sort of create a trend over the course of the visits. So really this is very much taken into the context of the clinical scenario, and it depends in a sense on the degree of elevation. Certainly there are also instances where people may feel like they're having a lot of symptoms, but the markers are not particularly elevated. And certainly this may be that the lupus is, still active, but it also may prompt consideration of other causes for the symptoms as well, to ensure that there are not other types of conditions or reasons for some of the active symptoms, that may or may not relate to lupus. So next we can discuss urine studies. So urine studies are really checked as a window to the kidney. So in general, we're very proactive in rheumatology about looking for any signs that the kidney may be involved in lupus, and really checking for any kidney dysfunction. Sometimes people can develop kidney dysfunction even if they're not having symptoms or otherwise feeling well. So this is something we screen for to be proactive about identifying it and managing it. And certainly urine studies are also used and relied on heavily when someone already has known kidney dysfunction related to lupus, to kind of monitor the course and monitor their response to treatment. So the common studies that are checked would be the urinalysis, which includes a variety of components, including protein content, white blood cells, red blood cells. Also, I didn't list it here, but you're probably also familiar with urinalyses being checked for purposes of ruling out urinary tract infections, and they include those components too. And if certain findings are seen on the urinalysis, the lab may send the urinalysis on for what's called a urine culture to look for bacteria and signs of infection. But rheumatologists are primarily looking at the urinalysis to look at some of the other findings related to kidney inflammation. Other studies related to the urinalysis that are often just processed from the same urine sample that someone's asked to provide at their visit would be urine protein to creatinine sort of quantified so that we can calculate a ratio. And that ratio is used to help us determine, kidney involvement and also, response to treatment over time. We monitor that ratio. It can be produced as a spot ratio, meaning based on a single urine sample that someone gives at a single point in time. And it can also be measured over the course of 24 hours. So sometimes, if additional information is needed, someone may be given essentially like a jug, a container to take home and actually collect their urine over 24 hours, which can be used to kind of quantify these levels. And as I've already kind of alluded to, urine protein content and protein to creatinine ratio and some of the other cell counts can be elevated in lupus nephritis, which is the term for kidney involvement or kidney inflammation of lupus. And we use these tests hand in hand with all the lab markers, but particularly the creatinine, which we covered in a previous slide, to kind of get a sense of how the kidneys are doing. So we've covered a lot of ground so far, and we have even a little bit more ground to cover. But I wanted to just take a step back to sort of summarize some of the tests that we've covered and think about them in the context of diagnosis and monitoring and what some of the common lab findings are. As I've mentioned a number of times, we certainly don't see all of these lab findings in everyone with lupus at any given point in time. And some people never have these lab findings, but just to kind of refresh your memory and give you a sense of some of the findings that you may see in the context of lupus. So often the double-stranded DNA can be elevated, C3 and C4, the complements can be low. Blood counts, so white blood cell count, hemoglobin, and platelet counts can be low. Creatinine, which is a measure of kidney function, can be elevated. The inflammatory markers ESR and CRP can be elevated, and the urine protein to creatinine ratio can be elevated, indicating excess protein related to kidney inflammation in lupus. So tests that are used more primarily with diagnosis, although some of them, particularly the antiphospholipid antibodies, may be checked over time, include the ANA, which is often positive or elevated, anti-Rho or SSA, which is often positive, anti-LA or SSB, which is often positive, anti-Smith and RNP, which are often positive, and the antiphospholipid antibodies, which are often elevated. So as you're aware, from your own experience or that of loved ones or friends, there are often a variety of tests that are checked in the context of lupus. And the tests that I've presented are some of the common ones, but obviously they don't constitute an exhaustive list. So I wanted to provide some examples of other lab tests that you may see checked in the context of lupus. And again, even this list is not exhaustive because there are a lot of different scenarios that can arise. But another test you may sometimes see checked would be the creatine kinase, or CK, which is a muscle enzyme that can become elevated in muscle inflammation related to lupus. Other tests that you may also see checked relate to exposure to different types of infections. These tests are usually checked when the rheumatologists or other related providers are considering starting medications to treat the lupus that would increase your risk of infection by lowering the immune system to basically fight the overactive immune system. And these are things we like to be aware of in advance so that if someone's had an exposure, we think about that and make the appropriate treatment recommendations and potentially consult with other colleagues. So some of the sort of routine infectious studies that are often checked would be quantiferon, which reflects tuberculosis exposure, hepatitis B surface antibody, surface antigen, and core antibody, which can either reflect prior hepatitis B exposure or prior vaccination. And there are different patterns to the ways that these tests return that help us kind of make the distinction between prior exposure or prior vaccination. And of course, many people recall, that they've been vaccinated. There are also potentially additional tests that can be checked. And then the hepatitis C antibody, which reflects hepatitis C exposure. I also, this talk is obviously primarily on lab results, and I wish we had more time to go into non-laboratory tests in lupus, but I wanted to at least, discuss them briefly. I'm sure many people are already familiar with a lot of these tests from the context of their own experience or the experience of loved ones. So some of the tests that arise in the context of lupus diagnosis or care include x-rays, which, as you know or can imagine, are obtained of the joints, of the bones, to chest x-rays to assess for lung inflammation. Obviously, MRIs can be obtained to look for joint findings or bone findings, or certainly other findings in other organs as relevant. Another test that's often used in lupus is called a DEXA scan, and that's a special type of x-ray that looks at bone density. So, this is commonly checked in people with lupus, particularly if they've received chronic steroids or high doses of steroids, or they're anticipated to receive chronic steroids or high doses of steroids, because steroids, as many of you are aware, can contribute to bone thinning. So we like to be proactive about thinking how to treat or prevent that. Another common study that's checked in lupus is an echocardiogram or a TTE. This is an ultrasound of the heart. It can look generally at the heart's function or the heart's valves, and it can also look specifically for signs of heart inflammation or fluid around the heart that may be helpful in the diagnosis of lupus or in looking for manifestations of lupus. And then finally, I just wanted to mention renal biopsy, which is the process of obtaining a very small sample from the kidney to look at the findings under the microscope. This is not typically done directly by rheumatologists, but by kidney specialists or interventional radiology. And this is essentially to look for more definitive evidence of kidney inflammation to use as part of the process of determining whether kidney inflammation is present when the creatinine is elevated or the urine studies indicate excess protein. So I wanted to, hopefully I've addressed a number of the questions that people have in their minds just over the course of the talk, but I wanted to even go further and address some frequently asked questions that come up. So one question that we're often asked is, how often should lab monitoring be performed in lupus? I think this is obviously a very individual question, and it relates a lot to an individual scenario and to kind of an individual rheumatologist practice. So there really aren't hard and fast rules, but as you can imagine, when lupus is more active, they're checked more frequently, somewhere on the order of roughly every 1 to 3 months. Certainly if people are hospitalized, unfortunately, or their lupus is more active and they're being treated in the outpatient setting, they may be checked even more frequently. In people whose lupus is relatively inactive, roughly labs may be checked every 3 to 6 months. There's still a notion, even when people's lupus is relatively inactive, of checking the labs periodically, just to be proactive in screening, for any other lab findings that might arise in the course of the diagnosis. So another kind of frequently asked question is, how are lab values incorporated into monitoring of disease activity in lupus? And what if lab values fluctuate from one visit to the next? These are great questions. So there's a variety of ways that rheumatologists monitor disease activity in lupus, with the labs that we've discussed in the context of a variety of clinical findings and symptoms that people share with the rheumatologists. And there are a variety of tools, survey tools essentially, that have been developed for disease monitoring purposes. Obviously the goal with treatment and monitoring over time is to make people feel as well as possible and to be associated with low disease activity or state or even remission. We sort of talk about these concepts, and there aren't, single consensus definitions of concepts like low disease activity and remission. But in general, we think of someone as being in remission if the clinical and lab findings have resolved on sort of minimal medication, hydroxychloroquine perhaps, without prednisone or other immunosuppressive medications. But definitions may vary, and I think it's important for people to speak with their rheumatologists about their individual scenario with questions. In terms of the question of laboratory values fluctuating from one visit to the next, this is certainly something we see very commonly in lupus. Things fluctuate, people are feeling well, and I think every individual scenario varies. And I think, again, you and your rheumatologist speak, and the rheumatologist takes the laboratory findings really in the context of the overall clinical scenario and symptoms. And sometimes we do see fluctuations that the rheumatologist will monitor. And we're really, ideally following people over time and seeing people frequently and getting to know them such that we can kind of establish a trend and a trajectory that allows us to see how people are doing at any given point, but really over the course of time as well, over the course of years. So another frequently asked question would be, how does treatment, such as steroids, impact lab findings in lupus, and what else can be done to improve lab findings? So, as I've alluded to with the previous question, ideally steroids and other medications used to treat lupus are, improving the laboratory findings, and we're seeing, changes in the lab findings like resolution of low blood cell counts or improvement in creatinine. Certainly there's some instances, as I've alluded to, where we might see certain lab changes persist, and people are felt to be optimally treated, are feeling well, and the rheumatologist will monitor them, and that can be very individual. Steroids in particular, we talked about thinking of looking out for making sure your blood sugar is not too elevated, monitoring bone density. There's certain potential side effects unique to steroids that we also think about. In terms of what else can be done to improve laboratory results, I mean, obviously, exercising and eating a healthy diet are an extremely important, part of lupus care, in addition to following with rheumatology and, speaking with your doctor about the medications that are advised. There have been studies of exercise, for example, that show that they can improve exercise, can improve fatigue and health-related quality of life. In lupus, and is very important. Whether that necessarily results in changes in lab results per se, I'm not sure that we necessarily have the direct evidence to support that from research studies. In terms of how lab tests are used to monitor for medication side effects in lupus, this could be a whole talk in and of itself. Different tests have different forms of monitoring, and different sort of potential lab changes that we looked out for in the context of monitoring the tests. But by and large, the tests that I've already mentioned, such as the blood counts and the comprehensive metabolic panel, are used to monitor for side effects, at least from kind of a laboratory perspective. So in terms of some of the take-home points, I think really one of the main themes of this talk, as I'm sure you've already gathered, is that lupus is quite variable. The laboratory findings are quite variable, and it's really important to have a dialogue with your rheumatologist and just really feel free to ask whatever questions you may have. Lab findings can support a diagnosis of lupus. Not all lab findings are required to make the diagnosis, and some really aren't specific to lupus and are considered in the context of the individual. Lab tests are part of routine monitoring in lupus, and they can change over time and may be associated with lupus disease activity or the side effects of treatment. And improvement in lab findings tends to suggest response to treatment, but there can be certain scenarios where certain lab findings persist and are monitored. So I think I already said this, but I just, wanted to really emphasize again, if you have questions about your lab results, really please don't hesitate to ask. The electronic portal, for example, that's been introduced over the last several years has, I think, really facilitated communication with people's rheumatologists. And obviously people can see the lab results become available relatively quickly after the results are processed by the lab. There are some scenarios that arise that are important to consider and, discuss with your rheumatologist if you have any questions. Sometimes the electronic medical record may flag a result that the rheumatologist feels can be monitored. Sometimes lab findings may not suggest a clear explanation for your symptoms, and the rheumatologist may suggest further testing. And sometimes lab findings may prompt consideration of further testing or treatment, even when someone's not experiencing a lot of new symptoms, depending on sort of the degree of that lab finding and the nature of the finding. So in the last few minutes, and I do want to make sure to reserve a few minutes for questions if there are any additional questions, I just wanted to address or present, I should say, a couple of very brief hypothetical sort of case studies to illustrate how we might think about using some of the lab results in the context of diagnosing lupus and using lab results for monitoring. So let's say a 25-year-old woman without significant medical history experiences fatigue, swelling and discomfort of her hands and wrists, and a facial rash in a butterfly distribution. The woman is referred to a rheumatologist by her primary care doctor, and a variety of tests are checked, including the ones listed here, with the findings listed here. So the ANA is positive, the double-stranded DNA is positive, C3 and C4 are low, anti-Smith is positive, her white blood cell count and hemoglobin are low, and her inflammatory markers are elevated. So she's diagnosed with lupus, and she's placed on prednisone and hydroxychloroquine, both of which are common medications in lupus. Then, unfortunately, she comes back 3 months later, and she's sharing with her rheumatologist that she has some swelling in her ankles. And she also shares with her rheumatologist that when she was seeing her primary care doctor, she was found to have newly elevated blood pressure. It really had never been elevated before. So the rheumatologist checks a variety of tests for monitoring, and the rheumatologist finds a number of things. Her anti-double-stranded DNA is high, her complements are low, her white blood cell count and hemoglobin are low, and now her creatinine, a measure of her kidney function, is elevated, her inflammatory markers are more elevated, and her urine protein to creatinine ratio is now elevated, suggesting excess protein in the urine. So the rheumatologist discusses with her that she's concerned that her kidneys have become involved in her lupus, and the rheumatologist increases the prednisone dose and refers her to a kidney specialist, including to discuss potentially a kidney biopsy to make a more definitive diagnosis of lupus involvement of the kidneys. And they're beginning to discuss adding additional immunosuppressive therapies for treatment. So then I'd like to switch gears a little bit and very briefly present a second hypothetical case study that's going to sound a little bit similar. So this is now a 25-year-old woman, a different 25-year-old woman without significant medical history who's experiencing fatigue, hair thinning, and really just diffuse discomfort. So she's referred by her primary doctor to a rheumatologist, and the rheumatologist checks a variety of tests, including the ones listed here. And ANA is positive, and thyroid stimulating hormone, which is one of the thyroid function tests, is elevated. So the rheumatologist is concerned that she has hypothyroidism or an underactive thyroid, and she's referred to a thyroid specialist for further evaluation and treatment. So this really just illustrates that people can have a positive ANA and symptoms that potentially could have been consistent with lupus. But in this case, it seems that thyroid dysfunction, which can also be associated with positive ANA, is the more likely cause of her symptoms, and the treatment path obviously will be different in this scenario, focused on treatment of thyroid dysfunction. So with that, before we take a few minutes to answer questions, I just wanted to leave you with a page you may be interested in consulting for further reading. This is a page on the HSS website that covers actually some similar content to what we discussed and that you can refer back to, after this webinar. One of my colleagues, Dr. Siegel, recently updated the webpage, and it can be a great resource in addition to, I'm sure, many other resources available to review and have as a reference of some of the lab findings that can be present in lupus. So with that, I thank you so much for your time. And I think we're going to have a few minutes for any additional questions that came up. Thank you so much for your attention and your time.
Thank you, Dr. Lieber, for that very comprehensive presentation. At this time, I would like to transition over to the question and answer portion of the program. Just a friendly reminder, keep on using the chat box feature to submit your questions to Dr. Lieber this afternoon. And I'm going to begin with one question that we received during registration, and we'll also be checking the chat box for any live questions. So the questions that were submitted during registration have been grouped together. That way we can answer as many questions as possible. And we may not be able to get to all of your questions, but we're committed to providing an answer. So the first question that was received during registration is, what should I do if my labs present a number or measure that is alarming or worrisome to my physician and I am feeling well?
Yeah, that's such a great question. So I think, this is definitely a scenario that sometimes arises, where people may have lab findings that are kind of unexpected because they're otherwise feeling well. And sort of on the flip side, they may be feeling well, but the lab findings may not necessarily present a clear explanation. So I think this really runs into the idea that, this is all really an open dialogue with your rheumatologist. And I think it's important to discuss with the rheumatologist your concerns and questions and the rheumatologist's concerns and questions. I think there's certain lab findings that even if you're feeling well, may really just prompt the need for further testing or treatment to be proactive and may even change management depending on sort of the nature of the lab finding. But again, I think it's really an opportunity to talk with the rheumatologist, understand their perspective, they understand your perspective, and move forward from there. So thank you for that question.
Thanks, Dr. Lieber. Next question is, could lupus become inactive?
Yeah, so I think that's a great question. So certainly, I wasn't able to get into it in too much detail today, although I alluded to it. There are a number of tools that we can use to determine disease activity. They typically can contain a combination of sort of clinical findings and symptoms that people may share and laboratory markers. And based on some of those disease activity tools, some people may become inactive. It doesn't necessarily mean in all scenarios that the medications would be discontinued, but certainly there are ways that we can assess disease activity. And I think, again, it's an ongoing discussion with your rheumatologist based on how you feel and sort of what the rheumatologist is seeing from the lab tests and other forms of monitoring.
Thank you, Dr. Lieber. Next question is, do these labs stay steady or change and have to be caught at the right time or during flare?
That's a really great question. So the answer is yes, some of them stay steady and some of them change. So it's a great question, and I think a great insight that this person who's asking the question is alluding to. So some of the labs that we check, for instance, the Roe and the La and the Smith and the RNP, once those are present, we're not there may be scenarios where they're checked again, but those are typically not checked serially over time. They typically remain present. Some of the other labs, like double-stranded DNA, complements, inflammatory markers, et cetera, those really can fluctuate over time. Often we will see the findings change with flares, but sometimes even outside of a flare, we will see changes in those findings. So I think, again, it's quite variable based on the scenario.
Thank you, Dr. Lieber. Another question is, what's the difference between UACR and UPC and protein to creatinine ratio?
Right. So a protein to creatinine ratio, or UPC, that's an abbreviation. So UPC is often an abbreviation that you might see a rheumatologist write to indicate urine protein to creatinine ratio. And that's basically a ratio of protein to creatinine that's kind of used to quantify the degree of protein leakage to help determine whether the kidneys are involved in lupus. And once the kidneys are known to be involved, to kind of monitor the progress with treatment.
Thank you. And another question is, for the ANA, is it possible to have a staining pattern change?
Yeah, we certainly see that there's some variability, including according to the labs. And I would say that, there are a variety of reasons that may occur.
And going further, is how common is it for the ANA test to flip from positive to negative?
Yeah, that's a great question. We certainly see that sometimes, particularly when the level is a bit lower, to begin with. And I think, how common that is, I'm not sure that I can necessarily quantify that, but I can tell you that it's sometimes seen.
Thank you, Dr. Lieber. And in patients with lupus, does Coombs ever become negative?
Yeah, so I mean, there can be scenarios where it's negative. I think that's maybe the subject of another talk and sort of discussion with hematology, but great question.
And lastly, what criteria would warrant retesting antiphospholipids?
Yeah, so that's a great question. So sometimes after the antiphospholipid antibodies are checked at an initial time point, they're often checked about 12 weeks later to see whether they've fluctuated. Other clinical scenarios that might warrant rechecking the antiphospholipid antibodies would be if someone develops a blood clot, although there are questions about checking it in the context of the clot, or has pregnancy complications. There are certain other what are considered non-criteria manifestations of antiphospholipid, like ulcers and other things like that. So it's hard to answer that question really specifically. There might be a variety of scenarios when that need arises.
Thank you, Dr. Lieber, for this great presentation, and thank you all for your participation today and joining us. I will now hand it over to Priscilla, who will wrap up our presentation today. Thank you.
Thank you. Thank you, Allison. Thank you, Dr. Lieber. Thank you all for your wonderful comments. We agree this really was a wonderful and comprehensive